Right. Well, we'll start going. I know we'll have others joining us as we go. Welcome. Thank you so much for joining us for this webinar on comorbidities and substance use disorders and understanding the connection. I'll be handing over and introducing our two fabulous doctors shortly. But before I do that, we'd just like to acknowledge country, and I'm learning Gadigal language at the moment. So Budjeri Gumara, or good day to everybody. We'd like to acknowledge First Nations communities as the traditional custodians of the land and waters on which we live and work, and acknowledge and respect their continuing culture and contribution they make to life across this country, which will be broadly represented in our audience today. I think we've got people from almost every state and territory joining us. And also would like to acknowledge the current efforts to establish an Indigenous voice to Parliament, which reaffirming the vital importance, I think, of Indigenous perspectives, knowledge and rights in shaping our shared future. So welcome and thank you for joining us, everybody. I'm going to introduce very briefly myself, and you won't see much of me after I've done that. So I'm Pia Clinton-Tarrastad. I'm the Chief Executive at Clean Slate Clinic and a health economist by background, and absolutely not qualified to talk to you on this topic, but I have two fabulous medics with us who are. So Dr. Hester Wilson, who is both a GP and addiction medicine specialist, and I'm pretty sure everybody on the webinar will know her well. She's very well known in this area and is the chair of the special interest group for the Royal College and has done huge amounts of research and education in AOD and really supporting to drive the agenda and the changes we need to see in the sector. So thank you so much for joining us, Hester. And Dr. Paul Grinzi, who is a specialist alcohol and other drugs GP, amongst other interests as well, and has also done a huge amount in GP education in addiction as a medical educator and a clinical lecturer at the University of Melbourne. And between them, we have two powerhouses who can talk to us about substance use disorder and comorbidities. So without further ado, I will hand over to the experts.
Thanks a lot, Pia, and it's a pleasure to be here with Hester and Pia and yourselves and those listening to the recording. Welcome to this recording as well. I'm really excited about this topic because I was just saying to Pia before we started recording that for those that work in just the AOD sector or just the mental health sector, the idea of comorbidity sounds like a complex disaster that needs special training. And as a GP, I'm thinking, well, this is just bread and butter stuff. This is what actually the community come up with. They come up with comorbidities and just what we deal with. So I'm really excited to share some insights, but also really to have as much as a conversation with you as possible. This is less about a presentation and more about a conversation and talking about how we do things and certainly learning from each other. Hester, how do you see the comorbidity before we get the audience to actually, while you're giving us your insights, can I get everyone in the chat room or go to the chat room and just provide your thoughts around what this actual word comorbidity means for you while we hear from Hester what it means to her?
Yeah, Paul, look, comorbidity or multi-morbidity is core to what we do in general practice. You know, it's kind of in our DNA as general practitioners. We deal with all of the issues that the people that come and see us present with. And it's really common to have multiple systems, multiple issues, and so I am always surprised when people go, oh, comorbidity, what came first? You know, it's all too hard, they've got to go elsewhere. But because for us, it's core to what we do in general practice, and we're really good at it.
Absolutely. And look, just in terms of, I forgot to introduce the structure of tonight. As I said, it's very much, the format's going to be very much a discussion based around some of the subtopics around this important broad topic. But in terms of questions, as they come up, please, there's the Q&A tab in your Zoom interface. Use that and we'll certainly combine those questions towards the end. We'll have some chance to answer those as we go. And any comments, any resources, anything else that's not really a question, chuck it in the chat room and share as well, because it's going to be really helpful to see where you're coming from, because I understand our participants today are coming, as Pia's mentioned, geographically dispersed, but also from an experience, those that have little experience in AOD and trying to learn this pretty much not for the first time, but just get their hands dirty just to start with, and those that have been doing this for many years and just want to sort of get some reinforcement, reassurance, and possibly a little bit of upskilling in certain sub areas. So a full spectrum, and everyone's obviously welcome in itself. To be quite simple, and not simple, not simplistic, a comorbidity is just basically something that co-occurs, both mental and physical health conditions. And I suppose the nice thing about working in AOD or with substance use, alcohol and other drugs, is that it spans both of these. Certainly, all the substance use disorders are official DSM-4 diagnoses from being a mental health disorder, but also most substances also have certainly physical complications, sequelae, or even predisposing issues that lead to this. So it can be quite complex, but the nice thing about working in this area is you get to test your whole skill set. It's not just a part of it itself. It's also important to know that comorbidity is not talking about necessarily about all disorders as diagnoses. You can have things that are sub-diagnostic in terms of their symptomatology, but still conditions that are important for us to consider. So they may not have major depression, but they've got depressive episodes and depressive emotions that may be, as an example, where it doesn't fulfill the criteria itself. Hester, do you have much information about comorbidities in general, about how they sit in Australia, what's common, what's not? Would you like me to fill some gaps?
Well, yes, thank you for the question without notice. But look, the bottom line is that comorbidity is really common. And it's different across ages and across genders as well. So women are very likely to have co-occurring mental health issues, so to have depression, anxiety, for example, whereas men are more likely to have a substance use disorder and a mental health issue. So there are differences across different groups in our community, but, bottom line from what I see is that comorbidity is the norm, not the exception. And so, there's always this thing that comes up around, well, what came first? And certainly, we're recognizing, and really importantly, starting to recognize the role that interpersonal trauma or other traumas have in people's experience of their mental health and their physical health, and that they may in fact start substances to help them manage their distress, or they may start substances and then end up with distress and end up with mental health issues, or they co-occur at the same time. It's a very complex issue. And one of the things that's often happened, and it's been, I'm going back a few years here, so please forgive me because it has changed, but in terms of mental health, specialist mental health services saying, oh, I'm sorry, yes, this person's got some mental health issues, but it's to do with their substance use. They've got to deal with their substance use and be abstinent for 6 months before we can make any conclusions about their mental health. And I get it. From a purist point of view, I get it, but it's super unhelpful, particularly for us as GPs, because we're seeing people that are substances have become harmful, or potentially risky, and have distress as well. And it sometimes it is possible for people to say, I'm going to take a break from my substances so I can sort out my mental health. But very commonly, they're using substances to manage their mental health and waiting for that to change. It's a perfect world, which sometimes occurs, but often doesn't. So it's really, how do we get down in the weeds or in the swamp, as our good colleague, wonderful colleague Louise, I've forgotten Louise's last name, Swamp Warrior, Stone, talks about, that we're down there in the weeds dealing with all this complexity and the murkiness of human experience. Is that what you wanted me to say, Paul? Have you got some kind of...
I think you've given us a lovely scenario, and you're very good with questions without any preparation prompting. So the other thing to consider is just thinking about my role as a GP with other areas outside of this area, and as you said, it's bread and butter to do with multimorbidity. But I suppose the difference between substance use and multimorbidity or comorbidity is that the age pattern's different. Because substance use is much more common in the younger age groups. We're often looking at this comorbidity much more in that, whereas for most things, as you get older, you develop more issues, whereas the substance use issues seems to sort of burn out and disappear or get treated to some extent.
Not always, Paul, and that's a really important thing for us to be thinking about as GPs, is to ask these questions of older people that we're seeing.
Yes, I make
and the issue that Yeah. And the issue that we have is as people get older, they might not be doing very much in the way of substances, but it's super harmful. So the two standard drinks that might be at lower risk in a 20, 30-year-old and a 70, 80, 90-year-old can have massive impact. And we may not think of the person that reminds us of our granddad, but we do need to ask them as well, because the pharmacokinetics and pharmacodynamics in older age shift absolutely, and we need to be considering it across all age groups. But you are right; it's younger age groups that are starting to experiment with substances and may end up with issues, and they very commonly present. But don't forget your oldies, and by oldies I mean anybody over the age of 40.
Oh, thanks for that. So, I mean, apart from age, other factors that lead to a higher prevalence of both these things. So certainly those socioeconomic factors are significant. They don't protect, you're not protected if you're in a privileged area, because it can affect all strata of society and does. But those with less privilege certainly have more challenges. And so we know that the physical, the emotional, the mental, and the substance use things more are likely to co-occur there. Similarly, with Indigenous populations, there's higher rates of substance use disorders and the comorbidities compared to the general population. Again, we've got to be cautious of making assumptions. You need to assess each person, but thinking someone is at higher risk, therefore I'm going to really make sure I do a thorough assessment rather than making some assumptions. Regionally, similarly, again, regional, rural and remote areas face unique challenges that often led to more comorbidities as well. But again, this covers all strata all across. And the more poly drug use there is as well, the more likely there is going to be one of those or a combination of those interacting, causing or contributing to some comorbid but other issues. I think you mentioned the gender differences.
But also people of diverse gender and sexuality, or LGBTQIA+ communities can experience more.
Yep. And the only other thing really is in terms of thinking about treatment barriers, the stigma, that side of things, which again, universal, but some cultures particularly will be much more sensitive or much more triggered by certain factors where other cultures or other parts of the community don't notice them at all. So there's certainly a complexity there behind us.
So Paul, I just wanted... Sorry, mate. I just wanted to put a flag in there in terms of women's experience of substances. And it is a unique experience that women have, and something just to be aware of, that women will experience harm much earlier in their substance use careers. And they also have the added complexity, and I'm not saying it's women only, but being bearing children, being primary caregivers, experience of sexual or interpersonal violence. So really there are some specific things for women as a group as well.
Yeah, absolutely. Yeah. So look, putting all that together, it's complex, which gives us the richness of our practice, but also the challenge of our practice to try and keep up to date and managing each patient as they walk through the door. Just a couple of examples of, particularly starting with the mental health, some statistics. These are a variety of commonly seen conditions or disorders. And you can see that the high prevalence ones are also high prevalent. Now, the baseline, the denominator here is the past 12 months of amongst adults with substance use disorders. So that's the baseline. And this is the prevalence of various mental health conditions and disorders for that cohort that are already using substances in the past year. So you can see, if you looked at this overall, there's no real surprises about what's more common. Depression and the anxiety disorders are number ones. I'm not sure you can have a number ones, but I did it anyway. So it's a plural number one. And the rest fall into place, some more, some less. There'll be some that are higher, like PTSD compared to some of the other ones, because that trauma history is a higher risk for developing substance use or exacerbating it. So there's a few little subtleties there. And what we know within our population at Clean Slate Clinic of what we're looked at is that the huge majority have coexisting mental ill health, not necessarily disorder, but mental ill health when we're measuring that in our assessment process. And of those, only about a third have actually access to a mental health worker, and we're using that term very broadly. So there's a big gap of 2/3 of the patients that we're seeing with mental health comorbidity actually have already linked in someone else to support beyond potentially the GP and the pharmacist who maybe already be involved. But so there's an opportunity there for all of us to consider comorbidity and looking at other support, so it takes the pressure off individual practitioners doing all the work, and also allows the patient to have a broader whole of person wraparound care type of approach.
So, Paul, I think it's interesting that this is mental health comorbidities at Clean Slate. And certainly my experience of the people that access care at Clean Slate is that they are a group of people who are housed, generally, have quite good mental health and kind of health literacy. And so certainly with the Clean Slate group, they are a particular group. In my setting where I'm working with disadvantaged, marginalised communities, it's even higher, and access to treatment is tricky for them.
Absolutely. Yeah, thanks. That's an important distinction. I do know that we at Clean Slate, it is some selection bias to get through. Find us, it's online, a whole bunch of things that are potentially not available for everyone, and all of us are obviously working in different areas and different parts of the community as well. So take our information and try and apply it locally, please. I did enjoy making the next slide just because of the graphic itself about, is it the chicken or the egg? There's been a few theories that have been alluded to here about whether the substance then creates in this case, a mental health condition, or whether the mental health condition predisposes to someone then sort of self-medicating with a substance around that. And it can certainly be either of those directions for various individuals. Ultimately, there's another theory as well to say there's an underlying factor that leads to both. And so it's not so much causality in one direction, but it's a sort of a more complex mix and a soup of complexity that these things sort of I won't continue with the metaphors, but it is complex in that regard. We'll keep the soup metaphors out of this itself. So there is a question then, sometimes academically more so than practically, of does it really matter what comes first? I suppose from a GP point of view, from my point of view, often we're dealing with trans diagnostically. It doesn't matter so much. We've got to just deal with what's in the room. It's nice to know sometimes. It often is helpful to know, I suppose from what we know in terms of broad things like social anxiety, specific phobias, post-traumatic stress, so the anxiety type of things often predate AOD. And a lot of it's, particularly there's more depressive sedating substances are used to help medicate and settle those anxiety symptoms. But interestingly, generalized anxiety and panic, as well as depression, dysthymia, often have their onset before the AOD use becomes a disorder. So I wouldn't make assumptions. It can be either way. And sometimes it can be helpful just to know in terms of formulating the plan and seeing what the primary issue is. But once it's established, they're often just commingled so much that it doesn't matter which one came first, because they're both feeding on each other. The substance use is creating comorbidities, and the comorbidities are feeding into the substance use itself. And so it is hard to tease out, and probably not necessarily, as we've said. And some of, as said, from a systems point of view, previously very, very unhelpful to try and, the AOD people won't treat someone with coexisting psychiatric issues because it's too complex and it's not clear enough. And those with psychiatric issues had to be completely substance free before they could make a diagnosis and get into treatment. And primary care was stuck with it. It's improving, but I'd still say where primary care is still stuck with more complexity because of the lack of funding and support than we deserve. But I think everyone's doing a great job considering the resources we've got available to us. I've got a little example of this complexity, and this is just an example. It could go the other way completely, but this is often what I see as a GP. And so someone may come in with mental health symptoms or have those initially. Then they use AOD on top of that, either because they're trying to help medicate their symptoms or it's just a comorbid thing. But often it's because the mental health symptoms are distressing enough, and they notice that alcohol or cannabis or whatever substance it was helps just alleviate that distress, so they feel better symptomatically. So sort of, it's I suppose from a legal point of view potentially, or at least an evidence-based point of view, misplaced therapy, but it certainly can be very effective to help reduce symptomatically. Over time, though, it becomes complex. It's not so linear, and often you get this cycle of increasing use, increasing symptoms, and the cycle continues. And the difficulty here is it's hard to pull yourself out of that if you're stuck. As you know, the substance will relieve symptoms, and even if you're trying really hard to stop often just the fact that relief is available to you, often readily available to us, then you end up lapsing back. And it can be a really difficult cycle. And that's, I think, one of the advantages we've got with Clean Slate is knowing this, observing this, and really allowing patients who are ready for some intervention to come in and break this cycle, so they don't have to feel like they have to resort to a substance to relieve things. We've got other ways and other support to help them, and we can learn a new cycle, which is going to be an important part of things going forward. So that's an example, but it could be the other way around. It could be the physical things first. This case, it was the mental health. How do you see in your practice? I know, Hester, you've got both a specialist addiction medicine practice as well as a GP primary care practice. From a systems point of view, I'm assuming there's a difference, but what difference is there in terms of how you interact with the health system?
Yeah, so look, I think the first thing that I'd like to say, and it's really important for us when we're thinking diagnostically, is are people increasing their drug and alcohol use? Have they actually developed a de novo substance use disorder or substance dependence? So because it's really important to tease that out. And if we're thinking the example of alcohol, we know that if somebody has developed a dependence on alcohol, particularly if they're drinking large amounts, that it is risky, medically, physically risky for them to just stop. So there is a risk of, seizures, of, a complex medical withdrawal with delirium tremens, for example. They're uncommon, but they do happen. So it is a really important thing when we're thinking diagnostically, is this risky, hazardous use, or is there dependency in there? So really getting a sense of what we mean when we talk about dependency, with withdrawal, with tolerance, with cravings, with salience. Those diagnostic criteria are really important. When I'm thinking about it from a GP perspective, really commonly people will come in expressing their anxiety or their depression. They won't come in and say, I have an issue with substances. And so it's really important. We've really shifted the dial in terms of people coming forward and speaking about their mental health distress, their stress, their anxiety, their low mood. Fantastic shift there. There is still some stigma about mental health, and Paul, you alluded to different cultural groups, that is an issue. But in the general practice setting, people will come in and complain about their mental health symptoms, but I have to ask them about their drug and alcohol symptoms. They won't always make the connection or feel comfortable disclosing what's happening. So really important to have that open, warm, respectful approach that assesses what's happening with their mental health, but also assesses what's happening with their substance use and their gambling and gaming as well. That can be other risky behaviours or dependent behaviours as well. In the drug and alcohol setting, I've got people coming in, for help with their drug and alcohol issues. So that's pretty kind of straightforward. They don't always tell you the full story because there's still a lot of stigma around disclosing what's happening. They will be quite worried perhaps about how is this, if I tell this person this, and I'm a parent, what's going to happen to my kids or my job or my driving, and those are across the board as well. They do happen. Of course, they're really important in the general practice setting, but quite often in the general practice setting, we've got a sense of what's happening in terms of their job and their kids and their family, because we see the whole family, and that's the fabulous advantage that we have in the general practice setting, is that we're part of that community and we know the family quite often.
Yep, absolutely. I was just thinking while you were saying that, how I would contrast it. I don't work in a specialist drug and alcohol sector, but my clean slate work, I suppose, is part of that to some extent, because it is self-selected, well, not necessarily completely self-selected, but they are selected patients. They've gone through an assessment process, and by the time they get to see me, there is a filtering process, and I realize at the back end, patients often say, oh, look, I'm starting my treatment here. And I often say, no, you're not starting. You're probably halfway through. You've done so much work to get to this point, usually with your GP, struggling, the emotional roller coaster, so much work. And now for me, it's pretty easy because you're already motivated. You're already here. with my GP hat on, I'm on the earliest part. You're working with your patients. It's much harder because the motivations are still in flux, and there's lots of other intervening things. And so it's nice to have someone to refer to like Clean Slate, because you know, we can sort of help out with a specific part. But the importance and the thing I like about this work is we certainly integrate with the existing relationship with the GP. It's not a separate thing. It's certainly trying to make sure happen with that. I was thinking about how I approach things as a GP, as opposed to having a filtered patient load here. And as you're saying, a lot of patients will come in with a presentation, symptoms themselves. And so it is complex. Some will come in and say, I need help with alcohol. I'm smoking cannabis too much, or my family members are. And it's a bit easier because it's already opened up, but certainly there's an importance. And so to explore that, most symptoms, especially if we're looking at alcohol, have a potential to explore alcohol. Whether they're coming with a sprained ankle, you can ask about things that may have led to tripping over, loss of balance, being pushed, violence, a number of things around even a sprained ankle. To most chronic diseases have a potential for alcohol to be intervening around that, because it does affect pretty much the whole body. So there are lots of opportunities, both the comorbidities or the presentations, to ask about substance use, and that they do interrelate. So that assessment is less medical student-like, where I'm just going to ask about the physical history, all the bits, and drug and alcohol fits under the social history, and just ask about, do you smoke, do you drink, and escalating the severity from there. It's more in flux. You're asking a bit about this, and you're exploring a bit the next bit, and see how does it relate to this. And you've got high blood pressure. When did that start? And your blood pressure medications, is that working for you? And oh no, but it hasn't been working since I started drinking more. And you're going back and forth. But the nice thing about it, you get the story with the patient. So the history, rather than being checklist, is much more narrative and story-like. And as you're saying, we get to know the patient, the family, the community. Through those stories, you really understand the background. And that's what I suppose I miss with Clean Slate, because we're coming in a certain role, and it's really important for the patient to be linked in with their GP, and we certainly provide that communication before and after, so they continue with that long-term relationship, which I know is really important as a GP in obviously a different setting itself.
Totally. And look, and that story that, and being the GP on that person's journey through life, the longitudinal therapeutic alliance that we have in general practice is just gold and such a privilege. Paul, the other thing I just wanted to flag, because you did mention it, is that quite often we will see a family member coming in expressing concern about a loved one, and so, for me, there's an approach there which is around supporting that individual that is coming in and seeing me with what's happening for them. They're my patient. It's also possible that the other person is my patient, but not seeking treatment. So then how do I support the person that I'm seeing to encourage their loved one to seek support? At the same time, I'm aware of the confidentiality, and I'm hearing this from one family member and setting up the confidentiality really clearly. I'm very happy for you to tell me what you need to tell me about the person in your life. However, I can't tell you what I know about that person. And likewise, when the person comes in, so that's one of the challenges that we have in general practice, is that we do hold secrets. And we are seen by family members, and how do we support them, build their sense of self-efficacy, put some support out for them, and help them to encourage that person to seek help. That person may never seek help. And so it may be that we continue an ongoing therapeutic alliance with their loved one, to help them manage it and help them decide how they're going to live their lives around another person's issues, health issues and behaviours.
I like how you phrase the concerned family or support friend, whoever the support person is coming in, as the index patient, really, because they're there for their helps. And I find probably the two areas that I find that I can help them most is with just information. Often there's so much stuff that they're just uncertain about. So some clear information about, and some good websites that are just, the Australian Drug Foundation have got some really nice substance specific stuff about just clear stuff. So there's less of the blogs and Facebook stuff, and it's more about, here's some clear information you can go for. There's some good resources about family support and family help, which can also be for friends. Websites that help support around that. And so there's the education part, and the other part really is just unpacking the judgment and stigma that goes with all of us. None of us are free of that. Some of us definitely try to be proactively trying to reduce it, but we live in a culture that's stigmatizing and judgmental around a lot of this. And so all of us will come in with various values, and some of those are hidden, some of them are very overt, but just trying to help the support person understand the condition for what it is and not what they fear around it, which is often where the stigma comes from. It's the fear and uncertainty. So just trying to break that down. Often I find that can be the most therapeutic approach as opposed to anything much more active, because they're the ones that will be often with the patient much more than I will ever be with them if I ever see that the other person as a patient. They're the ones that will be 24 hours a day potentially, as opposed to if they're my patient, they might be there at the most. If they're really intensively, I might see them 2 or 3 times a week for an hour. That would be really intensive. That's a small part of their week. The support person's there for the majority. So they're the ones who really can get the most if we can help that support person with their own, not survival mechanisms, because it's not about survival itself, but provide them with some support so they can make sure that they are well placed to continue. You're not going to get burnt out with the other person, but also be in a position to assist. So there's a lot of work can be done, even if the person using substances isn't in the room. Now, I just wanted to move on to a little bit more just about the harms. We're talking about mental health, and I do like the occasional image here. This is more triggering for me. I tend to drop my phone far too often, so I'm going to move on because I'm getting a little bit anxious. Physical health, and if we use alcohol as certainly the most common substance that we're dealing with at Clean Slate, and as a GP, certainly the most common things. I just wanted to put a thing out there looking at what the top 10 sort of broad health conditions, physical health conditions were, and so here they were. And I thought, can I group them? And I went, nah. There's a bit of everything there. And that's only the top 10. And if I look at what comes through our doors every day, I'd guarantee you a GP is probably seeing at least one of these. I'm being very, very kind here. At least one of these a day, probably one of these an hour. So there's opportunities to explore this. And it's not always going to be alcohol or other substance related, but there's an opportunity to open it up. And if you're asking regularly enough, it becomes something that you do, you're comfortable with it, and also something that patients hear. And so it becomes less of an issue if they do have to bring it up. It's been discussed before, at least been explored before around this. But there's a whole bunch of, this list can go on and on, because particularly alcohol, there's not one body system that isn't really affected. I'm thinking dentition, ocular health. There's things that aren't on the list here that absolutely can be a comorbid issue caused by alcohol, let alone those leading to alcohol use themselves. If you're willing to...
So they're just...
Sorry,
Paul. I'm just looking. Siobhan has written a really nice question. How do you both acknowledge the pleasure that people experience, often in contrast to other difficult, uncomfortable feelings and thoughts? They're part of living with a mental health condition when they use substances. Absolutely. Substances are amazing. They are so pleasurable, and people use substances to feel pleasure. And it's really important to acknowledge that pleasure. And I find when I'm talking to patients about the good things about their substances or the pleasurable things, they go, huh? Aren't you a doctor? Aren't you meant to tell me all the bad stuff? And I know the bad stuff. What does it mean for you? And so it's that really hearing the person's story and working with them through what are the good things about your substance use, what are the not so good things, what would your life look like? It's that motivational interviewing that helps them to really dig down into what is core for them about this. And really commonly when people have got, and certainly at the Clean Slate stage where they're going, I've got to do something about this, they know it's pleasurable, but they also recognize that the scales are tipped and there's more harm that's coming from it, whether it's themselves, their physical health, their relationships, their families, their kids, so they're at a point where they're going, I need to change this. It's still hard. It is really hard to change, but people do it. And it is, I think it's part of that treatment journey or that life journey that people will go on in terms of harmful, hazardous or dependent substance use. What do you find, Paul?
I just reflecting when you were saying that there's a couple of times when I say something to a patient that their demeanor changes. I love watching it because I know it's coming. And there's 2 examples. One you alluded to earlier where someone shouldn't stop drinking until it's planned if they're dependent with alcohol. So I say, you need to continue drinking. And that will take until we plan this properly. So I did this on the weekend. Someone wanted to do an alcohol detox with me on Saturday because I was working Saturday morning. I said, now is not the time. This weekend is not the time we're unsupported. We're going to do this on Monday. And they went, so what do I do? Keep drinking. But don't go overboard. But don't stop at this stage and go gobsmacked at the GP but with it in context. And the other one, as you're saying here, is really being curious and actually actively interested about how does this substance serve them. I don't use that term. What do you enjoy about it? What buzz do you get? How does it work for you? But really exploring that, not just to say there are goods and bads and let's focus on the bads to swing the momentum, but to acknowledge there's a balance. So even when we then start talking about the harms, it doesn't come across as a lecture, which is probably the common thing. I'm going to tell you all the bad things, and hopefully that'll convince you. Patients, all of us, don't get convinced that way. But if we're
people will know what the bad things are. Yes, look, it affects everywhere. And you can sometimes with a person, as you said before, it's become clear that this is actually stopping your blood pressure medication from working. But really commonly people will know the harms. So when I'm talking to them, I'll ask them, what are the harms that you're worried about? Or what are you aware of? Or would you like me to tell you more about the harms? And quite often they'll say, oh no, Hester, I know what the harms are. So really individualizing it, but acknowledging that alcohol along with tobacco, our two legal substances, are the most harmful ones that cause the most physical harm, morbidity and mortality, and yet they're the legal ones. And we get into such a fuss, and our government gets into such a fuss about the illicits, and I know they can cause harm as well, they do, but in comparison to to tobacco and alcohol, they're an piddling thing.
We'll talk about taxation revenue another time, which is probably the main factor behind that, and history as well. What was I going to say? I was quite enjoying that little rant you had there. It was quite nice. In terms of motivation, I do like the fact that you gave the example of getting the patient to describe their harms, and they're often very aware of them. But even the little technique that I use for patients who are more pre-contemplative, or less likely to disclose and say these are the things going wrong, I give them a hypothetical saying, what if in 6 months or by Christmas you had stopped? What would have happened between now and then for you to stop? And it's often like, I don't know, I would have got pregnant, or my dad would have died of this liver disease he's got, or something. And I say, okay, so they're the bits that are actually important to you, and then we can explore that further. So even talking hypotheticals often draw out things if people are more reluctant to talk about the here and now, or aren't ready to talk about the here and now. So again, and that gets a pre-contemplator to at least contemplate, bring it up, make it part of the agenda to have that discussion itself. We've got
there's another one there, Paul, from Christopher. Yeah. So, how many, we're talking about cognitive impairments, such an important issue. People I generally find are not aware of the risk of cognitive impairment. And he's saying, is there a need to raise awareness of alcohol-related dementia? Maybe people don't care as much about developing jaundice as developing dementia under the age of 60. I don't know whether you could say that they don't care as much about one, but certainly, cognitive impairment is a really important thing to raise, and to raise awareness about. The other thing is that the cancer harms that come from alcohol that many people are not aware of. And so certainly when I'm thinking about that, I would really be individualizing it to the person. But it's certainly, and it is one of the tricky areas if you have someone that has a significant history of alcohol dependence or harmful hazardous alcohol use, that cognitive impairment from alcohol itself, but also from injuries and head injuries, is something that we do need to assess, and it changes how you work with the person if they have a significant cognitive impairment.
Yeah, absolutely. I think one of the things that I did as a more junior GP, and certainly have altered since then, was try and find something to frighten them. So your dad died of this, you're at high risk, you might even die of this, you will die of this, or you're worried about falling pregnant. Well, if you keep drinking, your fertility will drop and you may not fall, all those sort of, it's still factual, but probably overplaying it to try and get a bit more of a fear factor to try and help motivate. And what I'm doing these days is saying, look, it can affect a number of things. It can affect sexual health, it can affect fertility, it can affect your bone health, it can affect this and that. Any of those relevant to your family or relevant to you, and then to get them to argue for it, rather than just trying to bombard them with information, which is something that you feel like when you're first starting off, you need to convince patients. Now I've learned that they need to convince themselves, and you just provide a scenario where they do the talking for you.
Paul, that is so true. I remember as a young GP, I'd be seeing people and thinking, you've got to stop this. I've got to stop this. I've got to get you to stop doing this. And it's like, no, it just makes me really stressed and it doesn't work, because the more I push, the more people push back. That good old, we want to stand up for ourselves. And so really shifting that around to a gentle, curious, respectful questioning that wants to understand what is happening for the person that I'm seeing and what's important to them, what matters to them, has really shifted, decreased my stress levels, I can tell you, and it actually works.
Yes, yeah, it's a lot of evidence behind that. I just want to go through, we've got about just under 20 minutes to go, and there's plenty of questions that will possibly still come through, and happy to answer them. But I just want to go through how we in Clean Slate try and navigate how to manage comorbidities. And for especially the GPs amongst us, you'll see this and going, really? That's just stuff we already do, because as we said at the start, this is bread and butter general practice. But there's a challenge we've got, because this is telehealth. It's nurse-led with some medical support. So there are some differences, both structurally as well as geographically, and a number of things that are different from what I would consider my normal practice as a GP. So the first one is just about assessment and screening, which we all often will do quite commonly. But we are using more validated questionnaires. We're actually making sure there's pathology behind this, and a number of things that, because we can't physically assess the patient, we'll be utilising those more remote or technology-based type of assessment processes. We've got quite a robust screening process to make sure there is a safety element, because taking someone through a substance withdrawal has its risk, and we want to make sure this is appropriate. And we're not appropriate, we're certainly very good at referring to the appropriate sources, often through the GP, but also through other secondary and tertiary sector support things, depending on what's required at the time. But trying to explain to the patient why we're not as suitable for them, but we're still there to provide some support, education, and still have some service. It's not just like tick and flick, they're not suitable. There's still some follow-up and making sure that they're on the right track with that as well. Another important part, I'm going to say.
Sorry, Paul, I just wanted to say, so one of the things that I see is really important for people where an assessment is made that this is not the most appropriate service for them, is that what we want to give everybody, including that group, is an experience of really respectful, person-centered care. And so what we want them to leave our service with is, I've had a good experience, that service cared about me, this is important, it's important for me to seek help in the appropriate place. So I think that's really core to the approach that we take, and it's an approach that works.
Yeah. For those that don't know, I'm controlling the slides, and Hester's just preempting the next slide without even realising it. It's about that whole wraparound care, and very much trauma informed. We know that trauma is going to be a significant component of a lot, but not all. And so just making the assumption, a universal approach that is appropriate to everyone, because the trauma won't always be disclosed, but it's important not to re-traumatize someone through a process. So trying to make sure it is holistic, trauma-informed, and patient-centered. So really, it's individualized. There are things that are fairly straightforward with a lot of withdrawal management processes, but still individualizing it for the circumstances. And that's where that assessment is really important to us, so we can actually make those individual changes and be responsive to what's happening, both from a patient's understanding their resources internally, but also the resources they're reaching out externally, and trying to modify things accordingly. Another area of how to manage comorbidities that, in terms of what the Clean Slate thing, how we do things, is certainly that coordination of care, which I've alluded to. So important as a GP to make sure I'm involved in helping, because I'm really very central to the patient's care. And so we're very cognizant to ensure that the local named GP by the patient, and if they've got a local team, get them involved, as well as utilising other support services that are available at a distance. So we've got partnerships with SOPA in the country, Hello Sunday Morning, Smart Recovery, Turning Point, to allow online resources particularly to be utilised for both peer support, education, self-monitoring, a number of different things that often have been missed. And it's that wraparound, looking at the social aspects, psychological aspects, the physical parts, but trying to put all that together for a patient, because often there's a gap. And it's often, I often see the social aspect as often a gap. Everyone's been very biomedical and focused around that, and they're just lonely, they're isolated, or they feel they're isolated until they have a community to work with. So I've had a number of patients in the post-detox review talking about their first encounters with our Smart Recovery group, which runs on a Thursday night, how they speak my language, they're my people. they've never met each other ever in their lives, but all of a sudden 1 or 2 meetings and they feel like they've got a tribe they can at least lean upon when they're struggling and learn from each other. So it's lovely to hear that. And I think as I've taken that in my general GP work to try and make sure that the social network is a supportive and ideally physical. I think we're very social beings, and having people in the room with us is very helpful, but it can be a virtual room. It doesn't have to be always a person next to you. Sometimes the person next to you isn't the most helpful person either. So that is a gap that I've seen.
Certainly, one I think that we've missed there, which can be really useful for some people, is Alcoholics Anonymous, that have both face-to-face and online meetings. So it doesn't suit everybody, but Alcoholics Anonymous, Al-Anon and Al-Teen. So Al-Anon and Al-Teen are for families and teenagers or young people. But yeah, just that's another one that people can find. Those the 12-step fellowship programs for some people can be really, really terrific.
Yeah, slightly different. It's a similar purpose to some extent, the Smart Recovery, in terms of having a peer support group. Very different structured processes, and not everyone. Some will gravitate to one rather than the other. So I often say, test everything, see what sticks, and stick with what sticks, and the rest is for someone else, not for you. Because there isn't a one size fits all. But we do use evidence-based treatments and modalities. We've got a strong. All our clinicians are very well versed in motivation interviewing, cognitive behavioral therapy approaches, behavioral change approaches, a lot of the health interventional stuff with apps, books, YouTube videos, a whole bunch of things that are very easily translated in digital medium. And again, we've got a biased population who are actually accessing us via Zoom. So they've got technology, they've got internet. There's a few things that we know that we can't access a certain population, but for those that can see us, we've got those resources available to allow them to build up a bigger toolkit in terms of their coping skills. And so they've actually got more things they can draw upon, rather than what has often been just one size fits all. The alcohol or the cannabis or whatever it may be has been the only thing they've known that actually has helped them in how they're going, but had the flip side of the harm. So trying to broaden that toolkit out, as I use, have more tools in your kit. That means if one breaks, you've still got other things to turn upon. And if it's raining, the exercise program is, if it's outdoor based only, you've got something else to turn to. Just thinking about all the what ifs and then allow them to build up as they go along. Lastly, in terms of the broad recommendations, is basically things we do regularly as a GP, reassess and regular follow-up. That continuity of care is so important. And one of the things that we do at Clean Slate, which is, I suppose, fairly unique for a sort of a boutique sort of small intervention in the big picture thing, is that we do have that long tail of nurse-led follow-up for 12 months for a patient. So there is that continuity. It does taper off as hopefully the relationship with the GP and the local community and these other resources take off. So there's sort of hopefully intersecting wedges that for the patient's point of view, they've got continuing support. The balance just changes over time, but there is that long tail of nurse-led support with the same nurse the whole time where possible. So really that continuity of care is really important for us to foster for the GP and their local community, as well as within our service, so that to ensure that it's done as best as possible. There. Now we've got 10 minutes to go. I want to share before we finish, because this often ends up at the last slide and everyone's got to go, some of the resources we've used for this webinar. So the comorbidity guidelines are excellent for this topic. They're brilliant, and I put some QR codes there, so it saves you typing away, or you can just pause the video if you're watching the video and just type the URLs, but the QR code should get you to those websites. The alcohol treatment guidelines are really fantastic as a very practical handbook, more so than a guideline. It's really a handbook of how to do certain parts, what to look for, and again, a very practical thing, something I turn to quite regularly. We've got a number of resources that we've collated on our website, which you can find the GP resources, also patient resources that you may want to look at to share with your patients as you're going through that. And in terms of comorbidity information, New South Wales Health have also provided a report that we've linked to there. So there's some resources there that are broad, but also specific to comorbidities. So I wanted to get that in before we finish, because I'm always frustrated at the end of a thing where people throw up, here are the resources, throw up some links, usually no QR codes. The webinar finishes, I was like, well, I hope someone recorded that because I've missed it. So I'll leave that slide up there for a bit now. But there's an opportunity now just to explore questions, any other reflections Hester and I can think of at the time. But particularly, we're here for our audience, you guys. And so I apologize if you're watching this as a recording after the event. You can't, that's the advantage of being here live. You can actually ask the live questions. So I've had a few already, but any other questions, please throw them in and we'll to answer as many as possible as we go along.
There's one from Vanessa. Do you psych ed on what is addiction and what happens in your brain? People love that. In my experience, it's empowering. I think absolutely. I mean, I think that, you know, so from my point of view, the stigma and the silence and the trying to keep it secret and trying to manage it and not telling people what's happening because of the shame, you know, to really have it out there and have, this is legitimate, this is real, this is happening in your brain. And look, it is more than the brain, you know, because our brain is a complex thing. It's who we are, and it's how we interact with the world and how our bodies feel. You know, but certainly really just naming it for what it is and naming it in a way that makes sense so that the person can make sense of it for themselves is absolutely really empowering. You know, and the same is for mental health issues, that for some people, giving it a name so they know what it is. And I find this very much for people that are experiencing post-traumatic stress disorder, that there's this constellation of symptoms, and you know, it can be really tricky. And if you can really say, I think what's happening here is an anxiety disorder called post-traumatic stress disorder. And what I'm seeing here is the hypervigilance, the nightmares, the reliving it, the anxiety that happens with that, the way that is affecting you. It's such a broad, in so many broad ways, and there are good treatments for this, you know, so that we can start to change this. You can start to take control of this and understand this. I think the other thing for me, just moving on a bit, and then Paul, I'll let you have a go, but I just came to mind, is understanding that this is not a quick fix, that this is not and it's certainly one of the things, you know, with Clean Slate, where we're seeing people on that recovery journey and helping them to do a safe withdrawal process. It doesn't finish at the end of withdrawal. That I often say to people, that's just the start of your journey, and now it's an ongoing journey around halfway through your life. Halfway? Okay, maybe I should change what I say. You've already done all the work. Yes. But there's a continuation of the journey, which is around how you reassess your relationship with the substance, whether it be alcohol or whatever, and the place you want it to have, and how you manage that, and whether it is never touching it again, or whether it's having it occasionally, or whatever that looks like. But it's also what the rest of your life looks like. It's how your mental health is, and it's an ongoing journey, and it's part of being human, you know. So it's pretty precious, because it's part of our humanity.
Yeah, it's lovely normalizing those emotions and the experience and say, this is just being human. Reminds me of the patient I referred to earlier, who I saw this Saturday, who wanted to detox on the Saturday. He gave me this eloquent story of all the criteria that were happening. I'm thinking tick, 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 tick. And then surprisingly, he said, I'm not sure what's happening. I'm not sure what's going on. And so on my screen, I had a little shortcut that brought up the alcohol use disorder criteria, and said, let's just go through them. And we just highlighted the ones that were applicable. So I think out of the 11, he got 9 or something like that. It was quite high. And he goes, what does that mean? I said, that means you've got, and I named it and said, this is something that we now can help with. And he just stared at it, and there were just tears flowing, absolutely flowing. Yeah. And I said, that's fantastic. And he goes, what do you mean? I said, fantastic, because it shows it's important to you. You know, that emotion just shows that there's an importance behind it. It shouldn't be, you know, I think sometimes we try to give people tissues and make it go away. Allow the emotion to happen. And he was so open to what can you do about it then, because it was acknowledged that this is something he's been living with, stigma, unwilling to sort of possibly acknowledge or understand it. The other thing that came from the question that came up, we've just answered, or partly answered, was what is the psychoeducation about what is addiction? Well, how long have you got? And so if people want to look into this, there's a really good book called The Urge by a psychiatrist from America who developed alcohol use disorder. And it's a beautifully interwoven book about his story, but probably more so the history of substances, addiction, over many centuries, particularly in the last century, how geopolitics, a whole bunch of different things have intervened, particularly from, again, biased with an American side of things, but often our Australian culture with this has been sort of inherited partly, especially legally. And so it looks at different, the question is, what is addiction, both from a biological point of view, a neurobiological point of view, a social point of view, a legal point of view, all those complexities. And it's a really nice read in terms of just going through things without being too moralistic in any direction. And he interjects it with his story as well, which gives you a little bit more of a narrative to base it on. So it's not just a historical book. So that's something that people may want to have a look at as well if they're interested in the question of what is addiction. That's called The Urge. Any other questions before we wrap up altogether?
There was one right early on,
yes.
Paul, just maybe as a very last one, which I think I partially answered, which was a question around the role of Clean Slate in providing services to address comorbidities. And I sort of said, and you guys had a great conversation around actually the importance of the GP and their longitudinal relationship with the client. But I guess, is there more you think we should be doing in terms of services for comorbidities beyond what we already do in terms of holistic person-centered care?
Interested to see what Hester says as well, but I think for us, we're a relatively new organisation, and while we've got, if we on a map pinpointed where our patients and where our interventions have been so far, it's quite diverse. But as we get more experience in different regions, I think we'll get more experience about what resources are in those regions, and we're going to be much more able to be proactively involved with linking people in. At the moment, we're really being reactive at what's available, so from the GP or the patient telling us. And I think over time we'll have more experience geographically to say, we know that around the corner, example, around the corner or in your nearby town, there is, for example, a psychologist that gets this, and they may be the one you can sort of look at, rather than us not really knowing, because it's a big country. But I think over time we'll have a much better, so I think it's an area that we can work on and have systems in place to try and generate those resources in the background. So we, as I said, more proactively with some resource allocation on the ground, rather than relying on the GP and the patient to inform us. But that will take some time.
I think it's important that we don't duplicate what's already out there. So that we can't do everything for everybody. No service can. We're part of the treatment system, and so people can dive in and get the support that they need from us, and then we can kind of make sure that they're connected in with ongoing supports that are specific to their needs.
Wonderful. I don't think, unless anyone's got any final questions, I'll have to be very quick on the keyboard, because I know we need to finish promptly in a minute or so, but I think we've answered most of them. Thank you so much, Paul and Hester, for a really great conversation, and I hope those listening found it interesting. And I will send out a copy of the recording as well as the resources that Paul shared. So I love your little QR codes with the little tigers and things in the middle. I need to find out how to do that myself. So we'll share this with everybody, and just a huge thank you to you both and to everybody who's joined and asked questions and engaged with us, and look forward to the next one. If anyone has any requests around topics that they would like to hear about, do let us know. We do webinars on a reasonably regular basis, so we're very happy to take requests if there are things people want a discussion around. So thank you everybody, and have a lovely evening.
See you everyone.
Bye-bye.